Good morning, everyone. My presentation is on the impact of COVID-19 on economic well-being, mental health, and HIV risk among men who have sex with men, a mixed method study in a North Indian city. And I do not have any relevant disclosure to make. And in this study, we argue that in comparison to the general population, sexual and gender minority communities like men who have sex with men are disproportionately impacted by the pandemic. And if you look at, and in this study, I bring an empirical evidence from a low-income country like India. And if you look at some of these studies that are currently emerging, you see that there is a correlation between stigma, discrimination, and HIV risk. And much of these perspectives are also based in symptomic theory and minority stress theory, which indicate that sexual and gender minority communities like MSM experience stigma and discrimination in their everyday life. And this experience of stigma and discrimination lead to the prevalence of symptomic and or the co-occurrence of multiple health conditions or psychological conditions among them, which includes depression, anxiety, and internal stigma. And the prevalence of this symptomic conditions in turn have varied implications for HIV risk behaviors. So when we have these current perspectives in place, we were really interested in understanding how the COVID-19 pandemic is bringing a new perspective and shaping some of the current existing conditions. And we felt that there are limited empirical studies on COVID-19, on MSM in India. And in this context, our study became relevant. And in the study, we try to understand the impact of COVID-19 on economic security, mental health, healthcare access, and HIV risk among men who have sex with men. We also try to explore and identify potential interconnections between sexual stigma and COVID-19 related stress on psychosocial symptomic conditions and HIV risk. And this is one of the first studies that our group conducted soon after the initiation of COVID-19 lockdown in India. And this was a concurrent mixed method study conducted in a North Indian city. And we also had a set of eligibility criteria for the recruitment of participants. And the participants were recruited through community-based organizations involved in HIV prevention programs. And since this is a mixed method study, we had both quantitative and qualitative components in the research. For the quantitative part, we had a cross-sectional survey, and for the qualitative study, the qualitative study was comprised of in-depth interviews. And if you look at the survey kind of helped us to capture the current prevalence of psychological conditions among MSM using a set of standardized scales. And the survey also helped us to understand whether these health conditions are increasing during the period of lockdown. But on the other hand, the qualitative interviews were actually helping us to capture something that was missing in the survey, and that is people's perspectives and more insight into the impact of COVID-19. And even when we are looking at a broad category called MSM, in the study we ensured that we are also giving attention to the diverse gender expressions within MSM. And if you look at some of these survey findings, you see that a majority identified as Kothi, which is where the gender expression is feminine. A majority were about 25 years old and were single, had a college degree, and 43% were involved in sex work, and 8% were involved in 8% reported HIV positive. And for us, these findings were important because even when we are looking at the disproportionate impact of COVID-19, we also gave adequate attention to the intersectional perspective of MSM, because we feel that the pandemic is differently experienced by those who are engaged in sex work and also reporting HIV positive status. And if you look at the qualitative interview participants and the data, you see that in occupation, around 6 MSM were employed as private company staff during lockdown. And you see that out of these 6, 4 were reporting job layoff during lockdown, and from them, 2 of them were subsequently choosing sex work, which kind of indicate the economic stress experienced by our participants during the pandemic, and how they were actually, and their pathway to survival sex during the pandemic. And participants also reported mental health conditions. 2.3% reported depression, and 21% reported anxiety, and 4.5% also reported self-stigma. And then you see that these conditions were also cumulatively increasing during lockdown. And some of the factors, the COVID-19 specific factors like social distancing, was also leading to the prevalence of mental health conditions among MS, mainly because during lockdown they had to stay away from their social networks and the clients. And you see that in the logistic regression analysis, social distancing stress was significantly associated with depressive and anxiety symptoms, and internalized homonegativity was significantly associated with both depressive and anxiety symptoms. And remember, like I was mentioning about the intersectional angle, and you see that some of these conditions were more prevalent among those involved in sex work than those not involved in sex work. And this is a diagrammatic representation of what I'm trying to argue so far. So you see that during the pandemic, the participants experienced economic distress. Their access to services were disrupted, and because of stigma and discrimination, and because of the economic distress, they were also experiencing mental distress, and these were togetherly contributing to HIV risk behaviors. And if you look at the economic distress in particular, here I bring 2 categories of MSM involved in sex work and MSM not involved in sex work. So those MSM who were employed in other sectors either reported job layoff or had a decline in their daily wage or salary delay, which was actually pushing them to survival sex during the pandemic. Whereas MSM in sex work reported having less clients, and this was also leading to decline in daily wage income. And this economic stressor was pushing them to procure high interest loans, and some of them were pressurized by the money lenders to repay the pending loans, and this was leading to mental health conditions. And MSM with no family, with no support system suffer more loneliness, and lack of physical support increased virtual meetings through Grindr, Blood, and other social networking platforms. And it's important to see how the community was building resilience, mainly through the kind of support extended by community friends and community-based organizations during the pandemic. Participants also reported that their healthcare services were disrupted. 19% could not access condoms when required. 38% could not access HIV testing. 55% could not see a doctor for STD screening or treatment. 74% could not access counseling services. And and the qualitative interviews probed more into the reasons why these services were disrupted. And participants reported fear of violence, especially from the police, while stepping out. They also reported limited travel facilities, and they were also scared of virus infection, which had implications for their access to services. And then you see that during the pandemic, there is economic distress, and peer avenues are closed, and they also suffered loneliness and psychological distress, and they also had very limited access to condoms, which was also having varied implications for HIV risk. And here you see the narrative of participants involved in sex work. So remember, I mentioned that those who were involved in sex work already had less clients, and they were scared of losing the existing clients. And even when the clients were offering them more money for condomless sex, and they had to really go for it because of the heightened economic crisis. And then here you see that intersectional angle of MSM in sex work experiencing highest burden of HIV risk. And this is the diagrammatic representation of what I'm trying to argue so far. So during lockdown, participants experienced economic distress and psychological distress, which was leading to the prevalence of symptomatic conditions like anxiety, depression, and internalized stigma. And on the other hand, you also see that there is, the stigma has an intersectional dimension. Stigma is based on sexuality, sex work status, and HIV status. And this experience of stigma was also leading to the prevalence of symptomatic conditions among MSM, and this had implications for HIV risk. And during pandemic, because of the disruption in healthcare access, it was also leading to HIV risk. So in conclusion, I argue that COVID-19 has had negative economic and mental health impact on MSM, and it disrupted access to HIV services. Economic and psychological distress contributed to increased HIV risk. Resilience was demonstrated in access to emotional and financial support from peers. So we have a set of recommendations to make based on our study. We recommend innovative ways to be implemented to improve access to mental health services, maybe through telecounseling, and innovative ways are required to avoid disruption in HIV prevention or treatment services, which could be achieved through door delivery of antiretrovirals and field-based testing. And especially the third recommendation is very relevant for low-income countries, where we need to come up with innovative ways to decrease financial burden experienced during COVID-19, and this could be taken care of by the government by ensuring low interest loans. And at the end, I would like to acknowledge the Chandigarh State AIDS Control Society and project managers and staff of TI partners at Chandigarh, Family Planning Association of India, India Public Health Association, and Servants of the People's Society. And this study was supported by the DBT Wellcome Trust India Alliance Senior Fellowship of Dr. Venkateshan Chakrapani, who is the chairperson at C-Sharp, and also with the Humsafar Trust Mumbai. Thank you.
Thank you so much, Amina.